Sorry about that. So this is the welcome back webinar for the Missouri Antimicrobial Stewardship Educational Collaborative, or MASEC. We have been on hiatus for several months due to really some logistical difficulties. Now we should be back for most of the rest of the year at the very least. So today's webinar is going to be reintroducing people to MASEC, the expertise that it represents, the goals of the program, the webinars and case conferences that form the core of it, and the available resources that the collaborative is able to provide for hospitals who are performing stewardship in Missouri. And then the rest of the conference is really going to be demonstrating our monthly case conference or our monthly case conference program. So these are cases drawn from real life, modified slightly to emphasize certain points or to anonymize, that we use to teach stewardship approach and point out particular stewardship issues and foster discussion among the participants. Just a couple of disclosures. These webinars and the MASEC program in general are supported by the Missouri Department of Health and Senior Services with help from a Centers for Disease Control and Prevention grant. I, Kevin Hsueh, am a career hospital antimicrobial steward and an occasional recipient of medical care, so I do have an vested interest in people treating other people appropriately with antimicrobials. I'm also a collaborator on an investigator-initiated study of candidal infections funded by Astellas Pharmaceuticals. All these webinars are designed to be interactive sessions. They use Poll Everywhere, which is a totally free for the audience polling or response website. If everybody could go to this address. Where am I? I appear not to be able to, but go to the Poll Everywhere /MASEC website and register. It's literally just you need to put in your a screen name. It doesn't need to be your real name if you feel uncomfortable putting that down. But that will allow you to respond to the questions that we pose and also provide feedback that everyone can see. If people want to respond over the phone, make sure that you put in your audio pin so we have audio controls, but use your hands up signal right here. That's on your GoToWebinar control panel, and I should be able to see that on our, yes. And right now, Mohammed Al-Kalani has put their hands up. So I'm going to, just while everybody is logging into MASEC, I'm going to unmute that. Oh, no. Nobody is right now. So what we'll use the hands up signal for is if you want to be unmuted. Because right now, everyone starts muted and we have to unmute whoever wants to talk. Otherwise, we get a lot of feedback. It becomes a little bit disorderly. So this is how we're going to triage who wants to discuss things and who does not. And so if as many people as possible could log into the Poll Everywhere website and say that they're able to use Poll Everywhere, that gives us a sense of how many people are able to use this polling system and what kind of responses we should expect. Just FYI, responses to surveys and polls will be recorded and used to generate and improve future webinar content, because we're going to be asking questions like, what do you guys want to discuss in future webinars? And so this helps us identify where the questions are and what discussion needs to be formulated. All right. Looks like 20 people. We have around 31 people on the in the audience as far as I can tell. So I'm going to give it another minute so that we can get as many responses as possible. Even after we get off this screen, you'll still be able to go to that website and log in and start answering questions. So don't worry about getting left behind if we progress after this. I recommend trying to use your phone to do this. It actually works really well. They have a very good phone formatted question process, so it actually works really well instead of having to try to juggle the slides and the website. Okay, so I'm gonna push us along and let's get going. Okay, so the MASEC team is composed of myself. I'm Kevin Hsueh. I'm a physician of infectious disease at Washington University School of Medicine. My partner in this project is Michael Durkin. He is also a physician at Washington University School of Medicine. We're supported by Erin Rockmiel, who is a longtime stewardship pharmacist. That's her on the right. Our project coordinators, who will sometimes be emailing back and forth with people, is Tracy Habrock-Bach. And then we have many different physician subject experts because the realm of antimicrobial stewardship is quite broad. Jason Newland, who is a longtime and world-renowned expert in pediatric infectious disease and antimicrobial stewardship. Kayleen Matar, Jason Burnham, and Merelda Blanco Guzman, who are all infectious disease physicians specializing in particular areas within the Division of Infectious Disease at WashU. Our webinars and questions are sort of overseen by Dr. Ginger McKay, who's one of the dissemination and implementation research scientists at the WashU School of Public Health. And the reason we have her involved is really to make sure that the answers we're giving are as useful to the audience and to hospitals around Missouri as possible. So the goal of MASEC is to distribute stewardship expertise. Missouri has a very large number of hospitals, but they're spread almost evenly throughout the entire state. However, big academic centers are really found in a very few places. St. Louis being one and Kansas City being another, and then there are a few in between. Stewardship is a difficult thing to learn without very close proximity to people who've done it for a long period of time. Our goal with MASEC is to allow for dissemination of successful practices and also addressing common concerns, allowing these larger hospitals to disseminate expertise to the smaller hospitals around Missouri, and vice versa. I don't want people to think that this is larger hospitals telling smaller hospitals what to do. It's also trying to help smaller hospitals address the problems that larger hospitals may not have. The DOH is heavily invested in assisting with this process where it can, and if there's issues that require DOH attention, we can definitely help bring our partners into this. And sometimes you'll even see them on these calls. So the program structure, there's several different components to the MASEC program. We have a monthly case conference, which I'll demonstrate today. And then we have quarterly didactic webinars, or not quarterly, really monthly didactic webinars on separate specific topics. That's these special topical webinars. We also have on our website topical FAQs and other literature regarding the questions, common questions and questions that are brought up during these webinars. So you you influence the content. You guys will be determining what kind of questions we're answering. So the more that you guys engage and the more more questions you ask, the better that content will fit what your questions are. We have a single point of contact email, the mostewardship@worcester.edu email. This is the email that you should send questions to, comments on the webinars, future topics that you'd like to see. And I strongly recommend that people send, anonymized challenging cases to us, because part of this is to really learn how experts present or experts approach complex or difficult cases of stewardship. And this doesn't mean that it needs to be the patient is complex, but sometimes it's the administrative issues are complex. And we would very much like people to bounce ideas off of us. We're aiming for this to be, as I said, a resource for spreading knowledge and expertise. So the monthly case conferences, the monthly case conferences are drawn from real life collaborative members. They're designed to be interactive, so be ready to answer or pose questions during them. The conference structure goes like this. We present a case, we have experts discuss their approach to this type of case and issues that they identify. At the same time, collaborative members will be posing questions that we'll be answering on the fly. We'll have a Q&A with collaborative members, and that's particularly when you need to use that hands up system. And then we'll have a short didactic on the topic, and then after the webinars, we'll send out useful handouts and educational materials. We have a website, but we also send them out by email. We have separate special topical webinars, and these are hour-long seminars focused on a specific topic of significant concern and interest. Topics that were previously identified as significant interest or concern were the NHSN antimicrobial use and resistance module reporting, which is now a legally mandated reporting process, stewardship and highly resistant organisms, how we do stewardship in small community and resource limited settings, and then how to address inaccurate excessive allergy documentation and common pitfalls in stewardship communication. The webinar scheduling is still a little bit in the process of being developed, but we expect stewardship and highly resistant organisms to be presented in the month of March. That's later this month. The NHSN antimicrobial use and resistance module we were presented in May. Resources limited settings should be in June, and antibiotic allergies will be in July. These are tentative as of right now. I think that may change a little bit, but we'll send out scheduling reminders so that people know what's coming up. The FAQs and informational literature, they're going to be emailed out to all conference attendees. On our website, there's already a few that are available, like what is stewardship, how to address double coverage with antimicrobials, and common issues with skin and soft tissue infections. As I said, they're focusing on topics discussed during the webinars and requested by collaborative members. So you choose what we focus on. The Missouri Stewardship at worcester.edu email is our central point of contact. It's not for emergent or urgent clinical questions. We just are not staffed for a 24/7 consult service. But anything that's not urgent or emergent, we will try to address. So reasonable topics are recommendations on approach to certain cases, challenges that are being faced by your program. And of course, these, you don't have to say, what, if you don't feel comfortable with it, you don't have to say what institution you're from. You don't have to, you can anonymize your sort of discussion so that, it's only what you're comfortable sharing. Topics for discussion at these webinars, challenging cases, scientific questions. So I don't promise that we'll always be able to answer them, because some questions in stewardship are still out for debate and for research. Help finding additional resources, and then seeking advice and assistance from other collaborative members, and requests for template materials for pharmacists. The stewardship at worcester.edu email is staffed by Erin Rockmeal, our stewardship pharmacist, and she will try to discuss the cases as much as or discuss the issues as much as possible. New in 2019, there's you can request an over-the-phone consultation to discuss issues, because we found that doing things by email is somewhat laggy, we can schedule one-on-one calls with a MASEC expert to really discuss challenges to stewardship programs and identify potential resources that can be tapped. So now we're going to get to the cases. So I'm going to start with case one. This is a 35-year-old man. He's a heavy smoker. He was admitted to the hospital after a severe productive cough, fevers, and shortness of breath for 1 or 2 days. Remember, if anybody has responses, they can put them up, and they'll show up to the rest of the audience on the Poll Everywhere slide. On admission, this patient was febrile to 101 and tachy to 118 beats per minute, but normotensive, and he had a normal O2 set. He had a white count of 12, a normal creatinine, and his chest X-ray showed a left lower lobe infiltrate consistent with a pneumonia. A respiratory pathogen panel was done on an NP swab, which was negative, and he was started on the following: IV ceftriaxone at 1 gram Q24, IV azithro at 500 milligrams Q24, and then the patient defervesced after 48 hours and now is at day 5 on the same regimen. So I'm going to open it up to the experts for discussion. Erin, I'm going to put you on the spot if that's okay. What
Sure.
issues do you see with this case and in terms of stewardship? And so, just as a framework, we put together this little assessment tool looking at choice of agents, agent pharmacology, the approach to the physician, duration of therapy, and systemic issues and solutions.
Well, I would certainly at day 5 be wondering why they are still on 2 IV antibiotics if they defervesced after 48 hours. So that's
absolutely
a big question. And also, why 2 agents and why IV? They probably, I would say, I would be questioning the azithromycin at all at that point.
Right.
And I would also be asking about what their plan is for how long they're going to treat them. If they've been on for 5 days, is that something we really need to continue beyond that? 5 days is I think there's that newer literature that says that 5 days is probably enough if they've had a good response initially. Right.
Exactly. So I think the diagnosis is right? Left lower lobe infiltrate with pneumonia. Looking at it, the agents at least initially seem appropriate, but you're right. Day 5, and they're still on the same agent. This is a phenomenon that sometimes in the quality literature is called treatment anchoring. Sometimes when something's working, people are extremely hesitant to change things, even if the guidelines and other literature supports it. And sometimes they just need a little boost. So oftentimes, I don't know, Erin, how would you approach a physician in a case like this? What would you be? How would you approach a physician that way?
Well, I would be prepared and armed with my data, right?
Mm-hmm.
So you always have to be prepared. But I also, depending on your relationship and how well you know the physician, that makes a big difference in how you would approach the physician. For me, I always, tried to be non-confrontational. Of course, you get a much better response that way. So I always would start by asking questions at first, saying, I've noticed this patient, they seem to have had pneumonia. They were now on day 5 with 2 IV antibiotics. Do we have a plan for reducing that? I'm just wondering, if we really need to be that aggressive at this point. And then I just see what they say. Sometimes they say, oh my gosh, I've just been focusing on other things and I haven't even thought about changing therapy yet. Thanks for bringing it up. And then you come up with a plan. Other times you may find that, they're not familiar with some of the newer recommendations on duration of therapy. And so now I've got my data with me because I tried to be prepared ahead of time, and I can share that data and make my recommendations then at that point.
Right. And hopefully this is not something that you need, this sort of getting all your ducks in a row isn't something you need to do all the time with these physicians, because hopefully they begin to learn, right? You're bringing them literature that helps them improve their practice. One thing that I think from the stewardship physician side, we do the exact same thing. We try not to confront or assert, that we know better than them. We just try to bring them suggestions. Oftentimes it's accepted very, very well. One thing that just from the ID physician side of things that people may want to point out is an NP swab for respiratory pathogen panels. Many of these do not include all the bacteria that can cause pneumonia. So some people, so if they're positive for, say, flu or another organism, that's great. But just because it's negative doesn't necessarily mean anything. So the physician who saw the patient in the beginning was right in putting them on pretty broad spectrum coverage, because this doesn't tell you much when it's negative. So as a summary of key points, I think Erin pointed out almost all of them. So the appropriate initial selection, which covers typical and atypical bacterial coverage. The fact that azithromycin may not even be needed at this point at all. It has a 12-hour half-life and remains persistent in tissues for days after discontinuation. Classically, 3 days is sufficient if you're not targeting a typical bacteria like Legionella or Mycoplasma, where you know that you really need that much more coverage. That the physician is really probably just needs a reminder that the guidelines have changed, and now it's 5 days of therapy is sufficient if a patient is stable for greater than 48 hours, and that broad IV therapy is not really needed once a patient stabilizes. So I would usually recommend, if the patient had been stable for 48 hours, at the very least, de-escalating to a third-generation oral cephalosporin or levofloxacin, moxifloxacin, if you can't get them to not use a fluoroquinolone. And that 5 days of total therapy is now considered completely adequate for treatment of uncomplicated community-acquired pneumonia. Now, one systemic issue and solution I wanted to bring up is that you'll notice in this case there were no cultures that were done. And this is something that you should just remind your physicians. On-admission sputum cultures for people with productive cough have gone out of style, but it really is still recommended in order to tailor therapy. If you saw that this patient had strep pneumo, you could have stopped the azithro a lot earlier. If you saw that they had, a Staph aureus, you might actually extend the duration of coverage or add, say, vancomycin if it were MRSA. So this is something that physicians should be reminded is still a very important part of care. So I wanted to pose a question to the audience. What overall duration of therapy do you commonly see physicians use for community-acquired pneumonia? Because I've seen a lot of different practices on this. 10 days. So it looks 50-50, almost 50-50 split 7 to 10 days. At least there's no 14 days that I've seen yet. So don't be shy. This is anonymous. Excellent. So I'm going to give another 50 seconds or so for people to answer. It looks like 7 days is winning out. That's not bad, actually. That's bad. Ooh. And somebody put down 14 days. I've seen it happen. I've seen it happen with physicians who clearly should know better. So you're not alone. So Yeah, you can only pick one. Sorry. There will be other polls where you can put in as many answers as you want, but this is my just a general assessment of where things are. So it looks this data actually follows almost exactly where the literature says it is. So most physicians order somewhere between 7 to 10 days of therapy for community-acquired pneumonia. There is a small group of people who use even longer. That there are very few physicians, unfortunately, who use 5 days of therapy for uncomplicated community-acquired pneumonia. But that's actually 5 days has actually been the recommendation since 2007. So the American Thoracic Society and Infectious Disease Society of America guidelines say that 5 days is perfectly safe as long as the patient has been afebrile for 48 hours and doesn't have any other signs of severe disease. There was a recent, and this is the paper that Aaron cited, there was a recent JAMA Internal Medicine article from 2016, which looked at this on a very large randomized controlled or randomized study. And basically, this study looked at randomizing patients with uncomplicated community-acquired pneumonia to 5 days of antibiotics or whatever the physician wanted to do. And what they found was that there really was no difference between the two groups, except for how long they were on antibiotics. So the intervention group, clinical success at day 10 and day 30 for all patients, including patients with severe, that came in with severe community-acquired pneumonia, didn't seem to have any real difference. If anything, it was edging towards superiority of 5 days versus 7. Kind of not necessarily intuitive, but you'll see, like in the intention to treat analysis, which basically means they looked at what the goals were of what the patient was randomized to, and not there was a little bit of a improved clinical success for 5 days over the classic 7 to 10. The p-value was a little bit smaller. I don't think, given the numbers, this is really significant, but at the very least, they didn't show that 5 days was worse. So questions for the audience, and this is where you should raise your hands in order to, so I can open up the phone line. Any questions from the audience on the case? It can either be the points we discussed or any others that you come up with, even cases drawn from your own experience. Any questions or thoughts? I'll leave things open for a bit.
I'll just add while we're waiting, Kevin, that this is a situation where having institutional protocols really can help you out. If you have some institutional guidelines that help with duration and remind people to reconsider the route of therapy, that can help. And that helps your stewardship pharmacist too, when they see someone who's kind of falling outside the recommendations, that you have those institutional guidelines to show your physicians, remind them what your recommendations are.
Right, I agree. And different hospitals institute those kinds of guidelines in different ways. Some people just have basically an approved protocol guideline sheet, basically a paper that they distribute to, say, ED and inpatient and hospitalists. Some people actually have it built into their treatment order sets. A time-limited order to 5 days for IV ceftriaxone, or they have if we're talking about de-escalation, an IV to PO protocol, where sometimes even the pharmacist can do it themselves. Now, it's very much institution dependent, depending on what they accept. But yes, at least getting it hammered down on paper that this is the policy or general guidance of the hospital is very helpful. So I'm not seeing any raised hands or any questions. So we'll go on to the next case. So this is case 2, which is actually a case drawn for cases I have seen very frequently. So this is a 53-year-old male. He's got a history of IV drug use and was admitted to the hospital with a draining right shin wound for 2 weeks. At least he says it was 2 weeks. In the ED, he was febrile to 37.7. He had an elevated white blood cell count at 10.2, a normal creatinine. He had negative blood cultures and was found on CT to have tibial osteomyelitis, or evidence of something consistent with tibial osteomyelitis on his CT. He was started on the following: vancomycin 1 gram Q12 and cefepime 1 gram Q8. They took some operative cultures that grew MSSA. Now the patient's been on 1 week of IV vancomycin but couldn't be discharged due to insurance and concerns about misuse of long-term IVs. So somebody writes, why is he on vancomycin when the cultures grew MSSA? That's absolutely right. Vancomycin is primarily for MRSA, methicillin-resistant Staph aureus. So it's overly broad treatment for MSSA. Erin, what would be the agent you'd suggest they switch to?
Some penicillin, oxacillin-based agent would be recommended for MSSA over vancomycin.
Yeah, absolutely. Somebody writes, is cefepime needed? And yeah, that's a really good question. Cefepime might not be needed. Honestly, I'm not sure if on admission he really needed any antibiotics at all. It had been going on for several weeks. And, directed therapy for osteomyelitis. Osteomyelitis is generally not a problem that you need to treat right now. It's a problem that's going to be very long term. So I agree very much. Cefepime and just antibiotics overall might not be necessary. Can you give orals? That is a question we will be discussing right after this. And my supposition is yes, you can, but we'll give the reasoning why that is. Trough level, de-escalation needed, cultures and sensitivities of the culture are growing, need to switch to an oral antibiotic. Absolutely, agree with all of those things. And vancomycin, one thing I will point out, which is does anybody else in the audience get a little suspicious when they see vancomycin 1 gram Q12? I know I do. And that's because that's the quote-unquote standard dose of vancomycin. It's not usually, it's oftentimes used when people aren't really using weight-based dosing. So whenever I see 1 gram Q12, I always look to double-check that it's actually weight-based and not just somebody ordered 1 gram Q12 because that's what they've been doing for 15 years. And other people are saying need to evaluate the discharge antibiotic for IBDU. We'll need long-term antibiotics. I agree. IV drug use is an enormous problem for patients with severe infections because it just makes everything much more difficult. Another audience member says we always ask for pharmacy to dose. I think that's the policy. That's the growing policy at most at most institutions is that there's a big culture shift towards pharmacy dosing and adjusting and ordering levels for vancomycin. I'm a very strong support of that because while I respect physicians, there's a lot of different things they're trying to keep track of, and sometimes that one gets lost and it can be problematic. So I think we've already actually discussed a lot of the issues. Aaron, Mike, have you guys thought of any others about this particular case?
I think most of them have already been discussed. I'd like to get your thoughts, Kevin, on when you discuss orals, what the best oral agent is going to be. There's some concern about oral beta-lactam antibiotics not having great bioavailability. So
right.
I'd like to get your thoughts and Aaron's thoughts about if you did transition this patient to an oral antibiotic, even though it's MSSA, what antibiotic would you choose? Would you try to choose something that's got better bioavailability that's not a beta-lactam, or do you stick with a beta-lactam because you think that it's going to be more potent even though it might not get into the bone quite as well as other agents like doxycycline or Bactrim?
Yeah. So what Mike is talking about is the bioavailability of the agents, of which the penicillins are generally poor for oral bioavailability, and the bone penetration of the agents, where, generally most of the antibiotics have pretty good bone penetration, but when you combine the two problems, penicillins tend to look a little bit worse. Oral penicillins, or oral beta-lactams, I should say, tend to look a little bit worse. Aaron, what are your thoughts?
I would probably have to do a little research before I could answer that, because it's been a little while since I've
sure.
treated an osteo. But those are definitely good points to consider as you're choosing your antibiotic.
So I'm going to skip this because we already talked about almost all of these, and talk about the study that we are referencing, which is the OVIVA study, the oral versus intravenous antibiotics for bone and joint infection, that just came out on January 31st, 2019 in the New England Journal of Medicine. This was an enormous study done in Britain, looking at a randomized trial of intravenous antibiotics versus oral antibiotics for the treatment of bone and joint infections. And you can see the numbers are very large, and this is a multi-center study. So the 1,054 patients, around 500 of which went to the intravenous group and received at least 4 weeks of intravenous therapy, and 500 of which went to the oral group. The study group characteristics, I want to point out, are very similar to U.S. bone and joint patient characteristics. So there was a lot of diabetes, there was a lot of vascular ulcers, there were a lot of orthopedic hardware infections, some acute osteomyelitis, some chronic osteomyelitis, mostly extremity osteomyelitis, though there was some spinal osteo, though I think the amount of spinal osteo was a little bit lower, and therefore it might be a little bit harder to interpret. So what they found, so this is, and this is some commentary, this is the best study of oral versus intravenous antibiotics for osteomyelitis ever done. It's been very rigorously and critically reviewed by many in infectious disease and orthopedic surgery, and it's pretty sound. What they saw was that in many different ways of analyzing it, the oral group was almost always better than the intravenous group. Now, one caveat to this is they often kept patients on oral antibiotics for much longer than they would intravenous antibiotics. And oftentimes the IV group at the end of their IV therapy was put on oral antibiotics as well. So, be aware it's not always just a flat 6 weeks of therapy. But even in the worst case sensitivity analysis, oral entirely was still statistically not different than intravenous. And so the question that Mike brought up, which was, what agent do you use? In this study, around 16% of the patients on the PO antibiotics received penicillins. Most of them received, or more, the larger majority received quinolones, and that might be a little suspect nowadays. A good 10-11% received tetracyclines, and in this case, it was almost all doxycycline or minocycline. And then a smattering of others were given primarily clindamycin or azithromycin, and then I think there was a little bit of Bactrim in there, but honestly, they didn't break it out enough that I could tell. So when they looked at this, the penicillin seemed to do a little bit worse, but not statistically so. While everything else seemed to be superior to IV antibiotics. And let me just be clear, this is IV antibiotics after the first few days of therapy. This isn't, we're not talking about 2 or 3 weeks of IV antibiotics and switched over to PO. This is within the first week switching over from the initial empiric IV therapy to an oral regimen. So this study is really a bit of a game changer. I think it makes for a much stronger case in early oral transition of therapy for bone and joint infections. I think there are a couple of things to watch out for. They did not primarily target patients with patients with other complications of their infection, so bacteremia, metastatic infection, need for a limb for aggressive debridement or surrounding soft tissue infection. Those aren't really clearly characterized. So I would still be very cautious in converting a patient with a more complicated bone and joint infection over to orals, at least early on. I probably would rely on IVs a little bit more. That may be just a conservative approach to that, but I'm just not sure if the data is strong enough to really support early PO. Definitely not for bacteremia, but for those other severe infections, I wouldn't necessarily trust it quite as much. So any questions or people want to raise hands and discuss the OVIVA study? I'm going to open it up to people now. Fluoroquinolone use versus IV, which is safer? It really depends on what type of safety you're talking about. So fluoroquinolones they have been getting a pretty bad rap recently. So I'm sure most people are aware of the recent additional black box warning already over the many different black box warnings that fluoroquinolones have regarding the development of vascular aneurysms, in particular aortic aneurysms. These are long-term and broad epidemiologic connections. In any individual case, fluoroquinolones usually are pretty safe. Now, there are issues, primarily having to do with resistance. Our overuse of fluoroquinolones has really increased the resistance rate in the community to the point where I don't know if you can really rely on any fluoroquinolones for empiric coverage anymore. At least not except for maybe Levaquin for pneumonia, because at least for gram-negative rods, it really is pretty bad at this point. For long-term and deep-seated infections, there is a risk of development of resistance on fluoroquinolones, but I think the OVIVA study suggests that that's probably overblown. IV has its own problems. In particular, you can get thromboses, you can get line infections. So generally, I would say if you cannot use fluoroquinolones, you should try not to if you have another oral option. But if you have to use an oral fluoroquinolone, and IV isn't necessarily the safest or good option, I would probably choose the fluoroquinolone. Concern for endocarditis due to IV drug use. His blood cultures were negative, so I think some physicians would do an echo just to be sure, but I'm not sure it's an absolute rule for this kind of IV patients. I agree it's definitely a risk he has down the road, but I'm not sure just from this case stem, that you would have hard and fast indications for it. Screen the patient for HIV? Absolutely. You should screen this patient for HIV. That's not really a stewardship question, but as an infectious disease physician, basically everybody that comes through the ED should be screened for HIV if they haven't been before. I know it's somewhat controversial, but many actual states have implemented recommendations for screening almost all ED patients. Hepatitis C as well. He should be screened. It's a longer term problem. I doubt people would do it necessarily unless there were some concern that hepatitis C was a complication, because it's a long-term, often outpatient treatment issue. Anybody want to raise their hand? I'm watching the boards. I haven't seen anything. Anybody else want to pose a question about this case? I'm not seeing anything. Since we started a little bit late, I'm going to go on to the next case. This is really an open forum. If anybody has a volunteer, a case they want to volunteer, probably because we're running towards the end of the hour, we'll discuss it next time. But if anybody has a case they want to discuss, they can either raise their hand and we can jot down who it is, or send us an email, or write it down here, and we will get back to you and try to parse what we can answer. Anybody got anything? Let's see. Oh, Molly Grassberger. I'm going to unmute you, Molly. Molly, are you on the phone?
I am. Can you hear me?
Yes, absolutely.
So I have a patient right now. My primary issue with him is that he has Candida glabrata bloodstream infection. It's been persistent. They did imaging. They found out that there is a large fungal ball in the kidney. So they placed a nephrostomy tube. They've been on mycophenolate for the bacteremia. Mycophenolate isn't necessarily good for the urine and kidneys. There's lack of data there. With the amphotericin B deoxycholate shortage, just kind of wondering what to do since they're on the nephrostomy irrigation, but we won't be able to maintain that supply for very long. So what do we do from there?
That's a really hard case. No, I mean, and I'm not sure you guys are doing anything that we wouldn't do as well. My question would be, liposomal amphotericin B, is it available at your institution? Liposomal or a lipid formulation?
Yeah, so it's available. I'm just thinking in terms of systemic administration, it's not good for that area. I mean, it'd be good for the bloodstream infection, but again, source control. And I'm not aware of very compelling data to say that, it's good for urine kidney if you instill it directly.
Oh, no, I wouldn't. I would definitely not instill liposomal amphotericin B into the bladder, or into the nephrostomy tube or things like that. I would, I'm assuming you guys have sensitivities for the Candida glabrata, and then it's not sensitive to any of the azoles, because you don't want to use amphotericin. Nobody wants to use amphotericin generally. In this case, this would be one of those cases where the ID physician and me, where I'm not sure from the agent side you have anything additional you can necessarily bring to bear, except for maybe systemic administration of amphotericin, of liposomal amphotericin B, or some people would go a little off the reservation and even try something like flucytosine, but I'm not sure that makes any sense.
Yeah.
I would, that in the ID physician in me would say though that that's a case where surgical debridement actually would probably be the thing I would be pushing. That if you have a literal fungus ball in the kidney, or I'm assuming a fungal abscess or something of that nature, that really you need source control through surgical intervention,
Right.
or drainage.
The only issue is
you could stick a tube in there and try to.
No, go ahead.
No, I'm done with what I'm saying. Yeah. Did you want to add something else?
Yeah, no, I was just going to say I agree completely with source control. That's going to be the gold standard, especially in the setting of persistent bacteremia or fungemia. This is probably pretty clearly the source. I just think they're kind of thinking at this point, they're almost 80. Are they a surgical candidate, or what do the outcomes look like for that?
Yeah, you're not definitely in a good place. Depending on your resources, IR-based interventions, just trying to drain as much of that or decompress as much of that abscess as they can are often a possibility. But yeah, it's not easy, and especially in an older patient. I want to turn a little bit to the open forum questions. So somebody asked about practice experience info for AUC dosing of vancomycin. I think that's going to need to be a future presentation because even I am wrapping my head around it. I think it's a very contentious issue, and I don't want to do it injustice by just throwing off flippant answers. I think that is a topic that I will bring back for greater discussion at one of the next case conferences, if that's okay with everybody. Because, oh boy, is that going to be a whole systems change. Two problems. Physicians keep antibiotics on since radiological exams show infiltrates. And because the patient sounds junky. Second problem is that they keep antibiotics for a long time for pneumonia because it is IV antibiotics therapy are the only criteria to keep them on skilled nursing. Oh boy. So the first one we can definitely address. And actually that's a great topic for discussion. Basically, it's very clear from literature that there is radiologic lag for pneumonia in particular, in terms of how much the patient is improving. And it's not recommended that follow-up x-rays are done specifically for this reason, because people are inclined to treat what they see. The junkie aspect, well, that's a little bit different and is so subjective. It's not clear what can be said, but we'll try to address that. I will bring that back. If the people who had questions could email the Mo Stewardship email just so we can have a further conversation, so we can we can put together a good case for discussion by the group, that would be very helpful. The second issue is I'm not sure how to. So I've been told by, and this is just my experience, I've been told by our financial department and coders that really, especially with today's criterion, there should not be any way that IV antibiotics alone keeps somebody in the hospital or in nursing homes. But that may be different at different institutions. So I don't know how to answer that. I will look up any literature I can, but that one's a difficult one because it's really a per hospital issue. I would say ask your actual reimbursements people if that's actually true, because I think sometimes these kinds of myths in terms of, oh, well, IV antibiotics are the only reason that the person's here, sometimes get propagated through physicians' lines. We don't have that greatest understanding of of coding and reimbursement. So it's entirely possible that's not a correct assumption. So it is now 11:05. Any last thoughts or questions by anybody? I wanted to thank you, Molly, for bringing up a great case. That is a hard one. Yeah, I'm gonna, if it's okay, we'll reach out to you online over the email, because there may be other possibilities. We have some experts here. I'm gonna pose that question to them, because we'll see what they think regarding what's the best approach for that. We may not be able to get you a good answer, but we'll try. Anybody else? I hope people thought this was a good experience. As I said, we're going to be running this, and we're definitely funded through the end of July this time around. So this is a resource we're hoping will be long term. We're hoping to get renewal of funding and be able to keep this going as a resource and a educational experience for everybody. If people, come on. So I wanted to give special thanks to George Turablitzi, our Missouri State epidemiologist, who really has been pushing for MASEC to get for quite some time. He's been helping us arrange logistics, and he's going to be on some of these calls, and we could not do this without him. And then Allison Williams and Megan Griffith over at the Missouri Hospital Association, who have really helped coordinate this entire effort. I don't think any of this would work without them. I wanted to thank everybody for attending. We'll see you all next time, which is in around 2 weeks from now, again on a Friday. If people could give conference feedback, I'm going to leave this poll open for as long as I can possibly keep it open. This feedback really helps us both justify MASEC and make these conferences better and more useful for everybody. If people really like the open forum idea, since that seemed to work really well, we can start with that and run with it, and we'll just have the education be tagged on once people run out of cases. We are happy to do so. Yeah, just give us feedback. We're open, and be as harsh as you want or not. We're happy to help. I hope everybody had a good time today. And we'll see you again in 2 weeks. That one will be a topical session on how to deal with highly resistant bacteria, and it will be led by Jason Burnham, one of our MDRO specialists here at WashU. And I wanted to sign off. Thanks, everybody. I hope this has been a good experience for people. Great.